Checking. Hello. So good evening, friends. Welcome on. We are going to start a class today on FMGE August 2020 questions. So I am Dr. Rajamendran here, faculty in Arise Academy. So this is streamlined in Arise Academy for their students, and they made it free for all the students. So hope I am audible. Yes, shall we start the class? So I'm seeing you on chat. Any doubt you have, you can post in the chat. The chat box is there. Please post your doubts if you have during the discussion time. If you have any doubts, please post it in the chat box. We are going to start the class now. A 2-month-old baby is having watery diarrhea and fluid leaking from the umbilicus. This is due to dash. Very simple, straightforward. People are telling like that. What they are telling means in FMGE exam all the questions are more of clinical based, and we had so much of difficulty in answering the questions like that. People are telling. But when I went through all the questions are very basic questions. Just very basic in the sense they are actually very commonly asked questions. They are made as clinical based, nothing else. So this is actually a case. Actually, what they will ask you is, this question is usually asked in previous exams. If there is a discharge from the umbilicus, if there is a watery discharge from the umbilicus, what do you think of? The question is very simple. A watery discharge through the umbilicus, we should think of number 1, persistent urachus. You should think of persistent urachus. Or number 2, you should think of persistent vitellointestinal duct. These are the two causes of leakage from the umbilicus, liquid discharge from the umbilicus. These are the two causes. Can you tell me which is the answer here? 2-month-old baby is having watery diarrhea, fluid leakage from umbilicus. Which is the best answer here? It is more of a watery discharge and fluid. In vitellointestinal discharge, it will be more of mucus. It will be thick secretion because it is connection to bowel. So the answer here is failure of involution of allantoic duct. Allantois is the embryological fetal part of urachus, which develops into urachus and it disappears. Let me draw you the image. So let me show you the image of that. So this is a picture showing you. Let me show you. This is a bladder. This is a bladder. From bladder, the median umbilical ligament is nothing but the persistence of urachus. The urachus becomes the median umbilical ligament that is usually attached to the umbilicus. So usually this gets obliterated by around 15th week of intrauterine life itself. 15th week of intrauterine life itself, this will get obliterated. If it is persisting like this, the urine from the bladder, from the dome of the bladder will come out through the umbilicus. So this is a classical thing I want you to remember. The urine from the bladder will come out of the umbilicus like this. This is known as persistent allantoic duct, also known as urachus. So this is one cause of discharge, and another cause of discharge, as you all will be knowing, this is a terminal ileum. Near the terminal ileum, we have a vitellointestinal duct. Please don't forget, we have vitellointestinal duct. VID, vitellointestinal duct is present. This duct is actually the proximal part becomes Meckel's diverticulum. You all know that very well. The proximal part becomes Meckel's diverticulum. If this is persistent, also you can see the secretion from the GIT coming out. Like it can be coming out like fecal content can come out, even some motion can come out, or thick secretion will come out. So this is persistence of vitellointestinal duct. So there are two ducts which are connected to the umbilicus in the fetal life. One is vitellointestinal duct and another is allantoic duct. So allantoic duct presence with urine discharge. I hope you are understanding. Any doubts you have, please type in the chat box. I am listening to a chat box. I am seeing your chat box separately. So this is our umbilicus. The persistence of first question answer is persistence of failure of involution of allantoic duct is the first question answer. So coming to second question. So anywhere you have a doubt, please ask me. I will answer then and there itself. A patient's mother, while bathing her child, noticed there was no testis in the scrotum. No testis there in the scrotum of the child. So this is a baby. The baby is when the mother is bathing the baby, the mother is noting no testis is present on both sides of the scrotum. Both sides of the scrotum there is no testis, and the scrotum is underdeveloped. and one testis was found in the inguinal region, and the left testis was found in the perineum, in the perineal region. So what is the diagnosis? So I hope you can answer this. Can you tell me what is the diagnosis? I want your interaction. Please tell me the answer. So what is this and what is this? So right side is an undescended testis, and left side undescended testis will not go to perineum. So it is, what is this? What is this left side testis? It is known as left side ectopic testis. I want you to remember this. Left side is ectopic testis, right side is undescended testis. So please type something in the chat box so that I will be understanding your listening. Am I audible? Dear friends, am I audible? Everything is fine. Around only 13 students are watching the class. Am I audible? Everything is fine. Please type whether it is fine so that I can keep moving on. Any doubt you have, any issues, please type the answer, because I will be keep on taking. There are 27 questions I am going to discuss. So just going to discuss in the next 45 minutes to 1 hour all the 25 questions to 27 questions. Any doubt you please post me. Okay. So the right side testis is therefore an undescended testis, and the left side testis is an ectopic testis. What is this undescended and ectopic testis? What do you mean by these things? So please remember, this is actually testis is brought to the scrotum by means of one tail known as gubernaculum tail. So gubernaculum tail is attached to the scrotum. That is also known as scrotal tail. Apart from this, there are also some minor tails. One tail will be going to the pubic tail known as pubic tail. So another tail known as perineal tail, which will pull the testis to the perineum. Another tail to the femoral tail. So like that we have the gubernaculum has 5 tails. The most important tail, the scrotal tail, is going to take it out. So pubic tail, perineal tail, femoral tail, all these are various tails present in the pulling of testis. So the testis being pulled to the perineum is known as ectopic testis. So we call the ectopic testis as the deviation of testis away from the normal pathway is known as ectopic testis. Arrest in the normal pathway, somewhere on the way it is arrested, it is known as undescended testis. So let me tell you the differences between undescended testis and ectopic testis. So please don't forget undescended testis and ectopic testis differences. So undescended testis is an arrest in the normal pathway. Ectopic is deviation away from the normal pathway. And the most common site of ectopic testis is towards the superficial inguinal pouch. Please remember, it is towards the superficial inguinal pouch. That is the most common site of ectopic testis. The most common site of ectopic testis is to the superficial inguinal pouch. This is by means of one ectopic tail known as inguinal tail. So there is another tail. I told you some tails here. No? So there is one more tail known as inguinal tail. So inguinal tail will pull it towards the superficial inguinal pouch. Pubic tail will pull it in front of the pubic symphysis. Femoral tail towards the femoral canal. Perineal tail towards the perineum. So the most common ectopic is towards the inguinal tail, that is in the superficial inguinal pouch. That is the most common site. Undescended testis, the testis is underdeveloped testis. Please don't forget, it is underdeveloped testis. Whereas ectopic testis is a normally developed testis. So in ectopic testis, the scrotum may be normal. Scrotum is normal or developed scrotum. Here scrotum is also not developed. Scrotum also not developed in case of undescended testis. Scrotum is also not developed in case of undescended testis. In ectopic testis, scrotum is normally developed. So please remember these points. Very important. And undescended testis has lot of complications, like testis is a mnemonic for undescended testis. What are they? T for torsion, E for epididymoarchitis, S for seminoma, another T for trauma, and I for indirect hernia can be associated, and another S for sterility. These are the complications of undescended testis. Whereas ectopic testis, there is only one complication, that is trauma. Trauma is the only complication of ectopic testis, but undescended testis has so many complications. I hope you are understanding what I am telling you, the difference between undescended testis and ectopic testis. The second question is asking about undescended testis and ectopic testis. Please don't forget this question. So right testis was in the inguinal region, means it is in the off the way on the inguinal canal, and left was in the perineum. So perineum is not a normal location, it is a deviation from the normal location. So we go for right side undescended testis and left side ectopic testis is the best answer here. So go for this answer here. Okay. Coming to the third question. So, a mother complains of that her baby is not drinking properly from the breast. So the baby is not taking milk properly and now complains of pain and swelling in the breast. What is the most probable condition? So if the baby is not going to take milk from the breast will engorge. The breast will engorge and they will have pain. Painful engorgement of the breast is a normal phenomenon. So if the baby is not going to take breast milk, usually the mother should express the milk. At least the mother should express the milk out. The mother is not going to express the milk out, the breast will engorge with the milk stagnation and it will cause pain. So that is the most common symptom in this patient. So if the history is different, little different. So foreign medical graduate exams, I would like to tell you, all these are basic questions, little twisted. So you have to understand the clinical scenarios of various diseases. All these are very common diseases. Once you come for CRI and if you answer these questions, no, you will feel, oh, that much easy question I missed during my FMGE days. Later you will tell. So in this same question, a patient complains of pain in the breast, swelling in the breast, plus fever. What do you think of the answer? Pain, swelling and fever. What is the answer in this case? Patient complains of pain, swelling and fever. Can you tell me what is the answer you feel? Yes, I am expecting your type. None of you are typing the answers there. I am waiting for you to type the answer. Once you type the answer only, it will be interactive. Otherwise, it will be like a recorded lecture. If you wanted a recorded lecture, I would have recorded and put it inside already. So I want you to be interactive. I want you to interact. So what will be the case when there is a pain, swelling, and if there is a fever? Pain, swelling, fever. Is that what do you think the answer may be? The answer may be yes. I don't know whether they have disability or chatting or something else. I don't know why you are unable to chat. At least you put a hi. At least you put some hi or something that I will understand you are on the flow. None of you are answering anything. It goes like a one-way class. If I keep on teaching. Unless you post something, no, it will not be more interactive. So if there is a pain, swelling and fever, it will be more of mastitis. So pain, swelling and fever is feature of mastitis. Okay, please remember that is mastitis. So mastitis is a more problematic condition compared with this condition. Mastitis, what should I do? So mastitis is due to bacterial infection of the breast. There is a bacterial infection seen in mastitis. The bacterial infection is treated by injection cloxacillin. Please remember the treatment of choice for mastitis is cloxacillin. The commonest organism causing that is Staphylococcus aureus. And there is mastitis seen. Sometimes they may disable the chat so that you will not be answering. So have you disabled the chat for the students? But none of them are replying. None of them are answering. I've seen nobody is putting anything in the chat box. So I'm thinking whether you have disabled them to chat. So please check out it. Or you just put a message, I will verify the chat. Okay. So this is injection cloxacillin. We have to give Staphylococcus aureus is the organism causing the problem. You have to give injection cloxacillin for these cases. So this is a clear-cut case of breast engorgement due to stagnation of breast milk. It is not due to mastitis. So if there is a fever, you should think of mastitis. The simple one word is missing there. There is no word fever. Therefore, this is a typical case of mastitis, breast engorgement. So coming to the fourth question, 40 years old female with a severe cardiac compromise. This is a classical point. Severe cardiac compromise. She had to undergo an operation for which surgeons gave clearance. Which of the surgery should not be done? So surgeons gave clearance to do surgery, but she is having a cardiac compromise. So cardiac compromised patients, we cannot go for laparoscopy. Please remember this again, a straightforward, simple clinical question. So we cannot do laparoscopic operation for patients who are having cardiac compromise. So the answer here is D. Laparoscopic hysterectomy is the answer for this question. So please remember, the answer for this question is laparoscopic hysterectomy. There is a problem with my PowerPoint. So any case of cardiac cases, we will not give laparoscopy advice. We will ask them to only do open surgery. We will not advise them to go for laparoscopy. We will only advise them open surgery. So this case is a typical case. We have to advise them only open surgery. We will not advise them for laparoscopy. In this picture, you are seeing the classical issues. There's a problem with my laptop. Once again. So in any cases, we will not advise that laparoscopy surgery. Please remember that. There is a problem in the PowerPoint opening. Just wait for a second. It's opening. So the answer for this question is D. So please remember the question. Answer is laparoscopic hysterectomy should not be done. Laparoscopic hysterectomy should not be done. You can do open surgeries for these cases. So move on to the next question. Fifth question. So very clear cut, simple question. Fifth question, you can easily answer the question. Cutaneous horn. A cutaneous horn. Cutaneous horn as shown in the image is associated with which of the following cancers? So all these questions I got from Arise Academy students. Those students gave these questions. Cutaneous horn as shown in the image is associated with which of the following skin cancer? So this is a typical sebaceous horn. You can see the typical sebaceous horn. This is associated with squamous cell carcinoma. Please don't forget, it is associated with squamous cell cancer. It is a complication of sebaceous cyst. You can see it is a complication of sebaceous cyst. The sebaceous cyst, the secretions dry out and they form this complication. They form a complication of drying out. That sebaceous horn is formed, and typically you can see the other complications of sebaceous cyst. Let me tell you, sebaceous cyst other complications include number one, Cox peculiar tumor. Cox peculiar tumor is also a complication of sebaceous cyst. The tumor will have an ulceration in the scalp and looks like a tumor, but it is actually not a tumor. It is only a infected sebaceous cyst of scalp, is known as Cox peculiar tumor. And another thing is the sebaceous horn is another complication, and sebaceous cyst can go for infection and it can get rupture. Rupture of the sebaceous cyst can happen. All these are the various complications of sebaceous cyst. So please remember, all these are various complications of sebaceous cyst. And sebaceous horn can go for malignancy. Sebaceous horn can go or it can even underlyingly it can have a squamous cell cancer of skin. Okay. Sixth question: patient suffering from ulcerative colitis with presence, a known case of ulcerative colitis presents with an ulcer on the anterior leg as shown. This is a classically asked multiple times repeated national board question, and if this question you have not answered means you have not seen older question. This question has been asked so many times. And what is the most common skin manifest of ulcerative colitis? The answer for this is most common skin manifest of ulcerative colitis is pyoderma gangrenosum. So please remember, the most common skin manifest is pyoderma gangrenosum. This is a classical picture of pyoderma gangrenosum on the image. So what is the most common skin manifest of Crohn's disease? What is the most common skin manifest of Crohn's disease? Can you tell me what is the answer? I am unable to see any of your answers. I don't know whether these guys have disabled your chat or something else, but I am unable to see even any hi or anything. Also, you are not posting anything, so I don't know whether you are able to type the answers or not, or something. Whether these guys have stopped the chatting. Sometimes what happens? No, the admin people would have disabled the chatting, so you cannot be able to. I'm also verifying why you are unable to chat. I don't know whether you are purposely not chatting or. I don't know why nobody is answering. That is why I'm a little thinking why nobody is answering like that. Yeah, now I am seeing the answers. Thank you. I'm seeing so many answers now. Thank you. So very good. Now I'm seeing the people answering. Thank you for this. So what is the most common skin manifest of Crohn's disease? Can you tell me what is the most common skin manifest of Crohn's disease? This is a repeat MCQ. I'm seeing the chat now. Yeah, thank you. So what is the most common skin manifest of Crohn's disease? Can you tell me, please? Any idea? Answer is erythema nodosum. Please don't forget, this can be expected MCQ next year. Erythema nodosum is the most common skin manifest of Crohn's disease. So that's great. Most of you have answered the answers previously. Sarvajit Kaur, Rishikesan, Sasi Murugan, Sai Taruni, all of you, very good, welcome. Now only I could see your chats. I'm unable to see the chat before, now I'm seeing the chat. So please remember, erythema nodosum is the most common skin manifest in Crohn's disease, and this is a pyoderma gangrenosum seen in ulcerative colitis. Okay. So now coming to the next question. This question, same question ditto has come in previous exam, in national board exam. The same question came in the exam. In fast, which of the following needs immediate laparotomy? This is actually that you can see in this picture 1, 2, 3. These are the 3 zones of retroperitoneal hematoma. And if you have hematoma in these zones, what are you going to do? So the question is, what are you going to do for retroperitoneal hematoma in these various zones? So number 1 zone, if you see in this picture, number 1 is a zone of hematoma in the aorta or IVC area. In aorta or IVC area, there is an hematoma. So there is an injury to the aorta or IVC. Therefore, there is a huge hematoma like this. It is zone 1. So to the kidney, there is a hematoma. This is zone 2. Hematoma in the kidney is zone 2. Hematoma in the pelvic region is zone 3. So we have 3 zones. Among these zones, who will need emergency laparotomy? Answer is only 1. Zone number 1 needs immediate laparotomy. So zone number 1 needs immediate laparotomy. Immediately we have to do laparotomy. We have to approach the aorta or IVC and we have to repair the vessels. In case of zone 2, we can go for non-operative management if patient is stable. Zone 2, we will go for non-operative management if patient is stable. Zone 3 also we can put a pelvic binder. Usually the pelvic hematoma is due to pelvic fracture. We can do a pelvic binder and stop the bleeding from the pelvic zone. So zone 1, immediate laparotomy. Zone 2, non-operative management. Zone 3, pelvic binder. And I would like to tell you, in zone 1, so please remember, it is a zone 1 which needs immediate laparotomy. This is aorta, this is IVC. To reach aorta, I have to do one maneuver. I don't know how many of you remember this maneuver. What is the name of that maneuver? To reach aorta, I need one maneuver. What is the name of that maneuver? That maneuver is known as Mattox maneuver. So Mattox maneuver is rotation of the right side structures. All these structures will be rotated this side. To reach the aorta, I will do a Mattox maneuver. So Mattox maneuver is to reach the aorta, we will shift the structures like spleen, pancreatic tail, descending colon, splenic flexure, everything will rotate this side. This is known as left visceral medial rotation. So left side visceral medial rotation is known as Mattox maneuver. Similarly, to reach the aorta, the IVC, I will rotate structures from here to this side. Right side structures like duodenum, ascending colon, all these structures I will rotate to this side. So we have to rotate these structures to this side. That is known as Kettle maneuver. That is known as Kettle maneuver. Kettle maneuver is to right visceral medial rotation. Very good, Sai Taruni. Very good. Mattox maneuver is for reaching aorta, and IVC, right side visceral maneuver, is for IVC. Very good, Akuna Matata. Mattox maneuver is correct. Sasi Murugan, I am going to tell you, you are asking for fast steps. So fast is not a big thing to remember. Very simple. So please remember. Now the latest thing what we do is known as E-fast. Extended fast. What are the structures you are going to see in this E-fast is It is an ultrasound done by even the casualty medical officer. So E-FAST is an ultrasound done in the trauma center by casualty medical officer. He will focus on pelvis. He will focus on right side hypochondrium, left side hypochondrium and xiphisternum. Can you tell me what are the reason? In this thing, left hypochondrium, we will look for splenic trauma, spleen injury. Right side, we will look for liver injury. Pelvis, you look for collection, pelvic collection of blood. And in the xiphisternum, we will look for what? We will look for pericardial tamponade. Pericardial tamponade, we look for pericardial tamponade, we will do for this xiphisternum. And right side chest and left side chest, right and left side chest also we see. Totally we see 6 regions in E-FAST. In right side and left side chest, if there is a pneumothorax or any fluid collection, we can find out on E-FAST. So E-FAST is focusing 6 regions. And E-FAST will detect any amount of blood more than 100 ml. 100 ml or more than 100 ml, if you have blood collection, we can diagnose with the help of E-FAST. Please remember, more than 100 ml, we can diagnose with the E-FAST, and it is helpful to find only intraperitoneal collections. Retroperitoneal collections not useful. So E-FAST is not useful for retroperitoneal collection, not useful for penetrating injury, not useful for retroperitoneal collection, penetrating injury, and also not useful for any hollow organ injury. It is not useful for hollow organ injury. These are the places where E-FAST is not beneficial. Okay, it is not useful for beneficial. So Sai Taruni, yes, liver spleen, that's correct. Majusha, that's right. Lung fields. Can you tell me what you see in a case of pneumothorax in lung field? What is the sign seen in pneumothorax in lung field? What you see in lungs? If there is a pneumothorax, what is the sign you see? Radiology question. I hope Khalil would have discussed with you about this lung signs. What is the sign known as? Barcode sign or stratosphere sign. Stratosphere or barcode sign is seen in E-FAST in lungs. Okay. So this is about the E-FAST. If I go into depth of each topic, it will take so much of time. But just I will give you the important doubts you have. Any doubts? Hakuna Matata, Cocker maneuver is only mobilizing the duodenum. Cocker's maneuver is only mobilizing the duodenum. In case of cattle maneuver, we also do Cocker's also. Cocker's also is done along with the cattle maneuver. Cocker's is also done. So when I am doing cattle maneuver, Cocker's also will be done. Please remember, it also will be done. Okay. Yes, seashore sign or barcode sign. Very good, Manjusha, and very good, Rahma. Both of you are correct. So coming to the 8th question. So a patient presents with a thyroid swelling, weight loss. The physician found presence of cervical nodes in the same patient and decided to go for thyroid biopsy. Histopathology report of the patient suggested presence of orphan annii nuclei. Which of the following is a likely diagnosis? It's a straightforward, simple, basic question. If you are going to make mistakes in this type of question, there is no excuse in FMGE exams, because this question has been asked as a 100 times asked question with that orphan annii nuclei is a feature of dash. This question has come hundreds of times. So answer is papillary cancer thyroid. You should never make any mistake in this type of question. These are all, though the question looks big, it is a straight one-liner. Orphan annii nuclei is a feature of papillary thyroid cancer, is a one-liner. Please remember. So this is orphan Annie. She is a cartoon character of your grandfather days. You have multiple cartoon like Shin Chan, Dora, Doraemon, all those are cartoons now. In your days of your childhood days, you would have seen Tom and Jerry and the Popeye show, etc. But this is a cartoon character of your grandfather days. Your grandfather days, they used to see this cartoon. So orphan Annie eye nuclei. She is known as orphan Annie. See the eyes. She doesn't have an eyeball inside like this. So same way, the nucleus will have no nucleoli. Therefore, they are known as orphan Annie nuclei. Therefore, they are known as orphan Annie nuclei. And you can see, very good, you can see the Samoma bodies. Very good. Samoma bodies are seen like this. These are the Samoma bodies, which are nothing but concentric calcifications. Concentric calcifications. Very good, Apna Matata. You have told all the points of papillary cancer you have mentioned. Very good. So coming to the 9th question, we have today 27 questions. Anything you want more clarity, tell me. Otherwise, this is actually a fast session on discussing all the 27 questions and answers with a brief explanation. Okay. Question number 7. So what is your diagnosis? You can see a gallbladder specimen here. You can see a gallbladder specimen here with a growth inside. You can see the growth inside. So this is a typical case of carcinoma gallbladder. You will not get any doubt in this. It is a straightforward case of carcinoma gallbladder. Carcinoma gallbladder is shown here, and you can see associated with some stones are also present inside. So there are also stones present inside the gallbladder. Usually, How many percentage of cancer gallbladder have associated stones? How many percentage of cancer gallbladder will have associated stones? It will be around 95% will have associated stones. 95% will have associated stones. Please don't forget this point. Okay, 95% will have associated stones. There is actually huge delay of what I am taking here and what you are seeing there. There is a huge delay. More than 1 minute delay is going on. That is why I am asking the question and I am taking different topic, but you are answering after some time. So that is huge delay is because of the streamline problem. They should have made it perfect, but there is a streamline issue. That is the reason there is a huge delay. More than 30 seconds delay is there. Yes, that's true. There are more than 30 seconds delay. Coming to the question number 10. 60-year-old woman, known case of lung cancer. Please read this question. This is also again a one-liner question only. Actually, this is also a one-liner question. All the questions which are all one-liner questions, no, they made it as clinical based question, nothing different. The difference, there is no difference. All the one-liner questions which are asked in your exams, they made as a clinical based questions. This is a case of lung cancer coming to you with a shortness of breath and there is neck veins are engorged, JVP elevated, heart sounds are muffled and breath sounds appear reduced on the right infrascapular area. So you can see, actually this question doesn't have heart sounds are muffled, heart sounds are heard, heart sounds are normal. The question was having heart sounds are normal, breath sounds appear reduced on the right side. You can see on the right side there is a lesion. Requisition of chest X-ray shown. The chest X-ray shows right side there is a lesion. That is nothing but the lung cancer. The lung cancer is usually a small cell cancer of lung. This is actually a small cell cancer of lung. The small cell cancer of lung has one important paraneoplastic syndrome. So I am telling you guys, most of you wrote it as cardiac tamponade, but please remember, cardiac tamponade is not a complication of lung cancer. Please remember, lung cancer will not produce cardiac tamponade complication. This is a case of superior vena cava syndrome. Superior vena cava syndrome will have all the points. It will have raised JVP. There will be same features. There will be difficulty in breathing. All those things because of the superior vena cava syndrome. It is a paraneoplastic syndrome of small cell cancer of lung. You just open your book and when you read lung cancers, small cell cancer, paraneoplastic syndrome seen as superior vena cava compression syndrome. SVC compression syndrome is a classical syndrome seen in small cell cancer. When superior vena cava is compressed, you all know very well the JVP will be raised. And the heart sounds are muffled was not there in the question. Many of you thought the question was having heart sounds are muffled, but it is not there. Heart sounds muffled was not there. Breath sounds are reduced on the right side because of the lesion there. So this is a case of superior vena cava compression syndrome. This is a case of superior vena cava compression syndrome. Please don't forget this. Okay, it is a superior vena cava compression syndrome. And there is one more syndrome. Some of you are confusing that syndrome here. As cancer in the apex of the lung. Cancer in the apex of the lung can compress the sympathetic chain and it can cause Horner syndrome. What is the name of that tumor known as? What is the name of that tumor? It is known as Pancoast tumor. Pancoast tumor. These are all typical one-liner questions for your exams. When you go and open your lung cancer chapter, one-liners, all these are one-liners. So Horner syndrome will have Pancoast tumor and this Pancoast tumor will be caused by squamous cell cancer. Please remember the type of cancer and the paraneoplastic syndromes. Squamous cell cancer is one which is going to cause this Pancoast tumor and small cell cancer is going to cause, very good Hakuna, very good. Small cell cancer is going to cause all these things. Small cell cancer is going to cause all the problems like, yes, very good, Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome is going to be caused by it. And also it is going to cause SVC compression syndrome. All these are going to be caused by this small cell cancer. So please don't forget these points. So this is very classical MCQ. This is a classical MCQ showing you small cell cancer of lung causing superior vena cava syndrome. So 35-year-old recently discovered divorced male is suffering from palpitations, headache and diaphoretic episodes. Palpitation, headache and diaphoretic episodes on recurrent basis. He visited the psychiatrist multiple times. So this is a classical triad. Actually, if you see the triad of pheochromocytoma, they will have headache plus sweating, severe sweating with palpitation. This is a triad of pheochromocytoma seen, more than 50% of them will have paroxysmal spells of pheochromocytoma. So this is a classical case of pheochromocytoma. So what should I rule is check for catecholamine levels to rule out pheochromocytoma. So check for pheochromocytoma by means of measuring catecholamine levels. So they may also have psychiatric visits. Why this question of psychiatrist visit is given? Please remember, there is a syndrome, MEN2A syndrome. In MEN2A syndrome, there is pheochromocytoma plus medullary cancer thyroid plus hyperparathyroidism may be there. Hyperparathyroidism may be one of the cause of psychic moans. So to give a clue, they are just giving you, leading you to the answer. They want you to answer as pheochromocytoma. That is why they are giving a clue. The patient is having multiple psychiatric visits. So the answer is psychiatric moans are seen in MEN2A. They are bringing to you, this is a young fellow, 35 years, so there are more chances of him to be a MEN2A syndrome. Is the point they wanted to bring you here. Okay. So you have to think little depth in each question. So now it's time, now you guys should start preparing more and more of clinical oriented way. So when you are reading some topic, put up more clinical emphasis. Put more clinical emphasis on the topic and you prepare more and more clinical oriented way. That will make you answer all the questions. I'm telling you, they have not made anything different. They made all the one-liners as clinical based questions. That's all. Then FMG examiners, they made all the one-liners as a clinical based question, and you are going to get the same pattern only for this coming exam also. So be ready to face the clinical questions based on your one-liners, what you read usually. Okay. So this is a classical examination, scientific findings, and I'm also seeing this FMG guys, examiners, they're also going to ask you more and more of clinical examination science. They are asking more and more of clinical examination science, and it is time you have to focus on clinical examination science of common swellings like thyroid, breast, hernia, all these things you have to look for clinical science. And a patient has present with a gross abdominal swelling and the following test is being performed to comment on the finding being elicited. So you can see one examiner is keeping his hand on the center, and other examiner is going to tap from here and he is going to feel the impulse here. So this is known as fluid thrill. Fluid thrill, very simple question. Fluid thrill is palpated. So for eliciting fluid thrill and for eliciting shifting dullness and for eliciting puddle sign. I hope you know puddle sign is make the patient in a knee elbow position like this. Make the patient in a knee elbow position like this, and you have to look for the dullness around the umbilicus. The fluid character will be near the umbilicus. You can see even 30 to 50 ml of fluid can be detected by puddle sign. 30 to 50 ml fluid can be detected by puddle sign. 500 ml can be detected by shifting dullness. 1 liter is needed for fluid thrill. 1 liter fluid is needed to elicit fluid thrill. 500 ml fluid is enough for shifting dullness. 50 ml is enough for puddle sign. You can elicit puddle sign with just 50 ml. It is a knee elbow position. Knee elbow position, make the patient lie down and you percuss at the umbilicus level for the fluid present. So shifting dullness, 500 ml, you can elicit shifting dullness. Tap percuss in this place, it will be dull. You make the patient lie down opposite side, you will see the resonance shifted there. That is a fluid thrill. This picture is showing you pucker fluid thrill, okay? A elderly patient with a hypertension fell down in his bathroom. Okay, elderly patient. Every word is MCQ. Hypertensive patient. Fell down in his bathroom, just in a bathroom. There is no major hit by any car or something else. It is just a patient fell down in a bathroom. His BP was 220/110 on admission. Which of the following statements is correct about this patient? Can you tell me? Which of the following statement is correct about this patient? Which of the following is correct about this patient? So this is a case of, I'm telling you, this is a case of CVA, your medicine case. This is a CVA case. Hypertensive patient suddenly developing a hemorrhage inside the brain. So it is usually an intracerebral hemorrhage. The most common site of hemorrhage is putamen is the most common site. So in this, antiplatelet drugs should not be started. Platelets are not going to do anything in this patient, and by reducing the BP, we are not going to do anything at this stage. We are going to reduce the BP, but most important answer here is putamen is the common site of hemorrhage. So this is a case of hemorrhage, intracerebral hemorrhage, and it is a patient with a CVA. It is a patient with CVA. So please remember, it is a patient with CVA. The patient presents with complaints of palpitations. On examination, his heart rate is 110 per minute. The respiratory rate normal. BP is increased. She tells that her mother recently expired due to some renal cell cancer. Some renal cancer, not renal cell. Mother expired due to renal cancer. What investigation you would perform to manage this case? So I think the examiners are more interested in endocrinology during that time, and they have asked more questions from endocrinology. This is also a case of pheochromocytoma. Please remember, it is a pheochromocytoma. Patient is having palpitation, increased BP, increased pulse rate are all seen in patients with a pheochromocytoma, and her mother also died, means there is a family history of pheochromocytoma seen. So what is the best thing to measure here now? So the answer here is 24 hours fractionated metanephrine values. So we have to measure 24 hours urinary VMA and metanephrine to confirm there is a presence of pheochromocytoma. So we need to do 24 hours urinary VMA and metanephrine to confirm there is pheochromocytoma. This is most important thing needed. Okay, please remember this point. So this is actually the previous question, that is not hemorrhage due to fall. The question is not leading to you to find out there is a hemorrhage due to fall. It is a case of CVA. Okay, it is a case of CVA. So putamen is a common site. So I will tell you that question also is asked in the exam. So hemorrhage due to fall is also asked in the exam. I will tell you that. Coming to the 15th question. 15th question, on post-operative day 2, routine X-ray was performed for a patient. So a patient who is operated, for example, let us assume a breast operation done or thyroid operation done. Patient is having no complaint of respiratory distress and is comfortable in the hospital bed. On bilateral auscultation, air entry is also normally found. What is the next step? A normal patient, in fact this question is telling a normal patient, a post-operative patient who is sitting normal, comfortable, no lung collapse, nothing. So what will you do? So nothing to do. Why should I do a needle thoracostomy? Why should I do a thoracostomy for a normal patient? Why should I intubate a normal patient with a normal saturation? Wait and watch and give supplemental oxygen if required. That's the answer. So very simple, straightforward clinical question. Very simple, straightforward clinical question. They have made this question to make you confused. They made the question to make you confused and answer it wrongly. So the answer is very straightforward. Answer is A. Okay. A elderly patient. This is a question some of you answer. No, yes, Sai Taruni answer. A elderly patient fell in the bathroom in the early morning and became unconscious and was rushed to the casualty. On arrival, he is having 9/15. NCCT was performed. So urgent non-contrast CT was performed. So please remember here history of LOC from time of trauma. The points important here are from time of trauma there is history of LOC present. Number 2 is an elderly patient and it is a trivial trauma. You can see it is a trivial trauma. It is not a major trauma. Just he fell down in the bathroom. There is no hit by a bus or any car. It is a trivial trauma. So these are all findings which will lead to subdural hemorrhage. You can ask, sir, why don't it be extradural? I'll tell you this is subdural hemorrhage only by the following points. Why I am telling this is subdural hemorrhage? Please understand the difference between EDH and SDH. EDH is due to rupture of middle meningeal artery due to fracture of Tyrion bone. Tyrion bone fracture causes rupture of middle meningeal artery, and this is very common in young people with a huge impact injury. It should be a huge impact injury. It should not be a mild injury. It should be a huge impact injury will cause middle meningeal artery rupture and there will be a collection in the extradural space. So it is a extradural space which will give you an appearance of biconvex appearance on CT scan. Which will give you a biconvex appearance on CT scan. On otherwise, SDH is due to rupture of bridging veins. So please remember it is rupture of bridging veins. It is usually seen in old age due to a trivial trauma also. Trivial trauma means a minimal trauma also can suddenly cause this. Especially these old age people are on anticoagulants. They will develop this more commonly. And they will have history of LOC from the time of injury. Whereas EDH will have LOC after some time only. They will have lucid interval. They will have lucid interval. Means normal period of consciousness. So in SDH, the appearance on CT scan will be concavo-convex appearance. Concavo-convex appearance seen on SDH. So please don't forget the EDH and SDH, the clinical scenario points. The clinical points between EDH and SDH, this is how you should prepare. So what are the points in EDH? In EDH, it is a young patient, there is a huge impact injury. Whereas SDH, it is a old patient, there is a trivial trauma. So like this, you have to keep preparing. You have to keep preparing like this. So the answer here in this case is typically SDH only. Telling you the answer here is SDH. Okay, don't forget this point. So coming to a very classical question, a young woman presents with a image shown below. There is white color and blue color and red color, crimson red color, triggered by cold temperature or emotional stress. Episodes usually affect the fingers and toes along with the numbness and pain in the affected areas. There is no underlying illness or comorbidity in the patient. Comment to the diagnosis. Can you tell me? So there are both, these both are possible. Primary Raynaud's phenomenon is also possible, secondary is also possible. The question is very clear, no underlying illness seen. So the best answer is primary Raynaud's phenomenon. Secondary is seen in scleroderma. Scleroderma or other collagen vascular diseases will cause this secondary. So this is a case of primary Raynaud's phenomenon. This is a case of primary Raynaud's phenomenon. Please remember, this is classically having a finding of white color will be there first, followed by blue color, followed by crimson red, This is due to vasospasm. The white color is due to vasospasm, which is going to happen, and blue color is due to veins are occluded. Crimson red, arterioles open, that brings crimson red. So this white, blue, crimson red, this three color change in the fingers is seen in Raynaud's phenomenon. So Raynaud's phenomenon of unknown etiology is known as primary. Without any known etiology is known as primary. If they are having some known etiology, it is scleroderma or collagen vascular disease. So 30-year-old car driver was involved in an accident. He is brought to emergency room with the complaints of breathlessness. On examination, vitals or pulse rate is increased, BP low, and temperature is also increased. Extensive bruising noted in the right side of chest. There are so much of bruising noted in the right side of chest. Bedside chest X-ray was done. So what is the best management in this case? So the patient was undergoing a bedside X-ray, and the X-ray finding based on this extensive bruising will be a flail chest. So this patient is having a flail chest. We are coming to a conclusion, probably this patient is having a flail chest because he is having a pulse rate increase and there is extensive bruising. That is the only clue we have. So extensive bruising on the right side of the chest. What can be the problem inside? So there can be breathlessness. It can be either flail chest or it can be a pneumothorax. So there can be a flail chest or a pneumothorax. If it is a flail chest, answer is we have to do elective intubation and positive pressure ventilation. If it is a pneumothorax, I should go for a thoracostomy. So the question is incomplete. I don't know whether in scleroderma also the same color will be there. In scleroderma also, that is white color first, blue color second, third is crimson red. That is a phase, triple color phase, white, blue, crimson red. It will be same. Okay. So question number 18, it is incomplete question. To be frank, it is an incomplete question. We can either go for a flail chest or a pneumothorax. I kept this question maybe a flail chest and I have gone for a elective intubation and positive pressure ventilation. I have gone for this question. So maybe the question recollection may not be correct, but please remember, flail chest will need elective intubation, pneumothorax will need thoracostomy. Thoracostomy means putting a needle and draining the gas. Okay. So this is a commonly asked question and it is a repeat one-liner for your exams. As a 60-year-old male has a chronic projectile vomiting, is continuously vomiting for a long period, having a significant weight loss. Which of the following electrolyte abnormality is seen in this patient? This is a case of GOO, gastric outlet obstruction. What are the features? What are the features of gastric outlet obstruction? Because of continuous vomiting, the patient will have decrease of H+, decrease of chloride. Please remember, he is vomiting acid, chloride. HCl is getting vomited. So there is decreased acid, decreased chloride. So therefore there is hypochloremic and metabolic alkalosis coming for the patient. So gradually what happens, to conserve the H+, what happens in the kidney? The kidney will start, the kidney function is the tubules will cause, they will prevent H+, therefore to neutralize this, they will start absorbing bicarbonate. Once they are absorbing bicarbonate, they will exchange sodium for bicarbonate. This is a channel. Sodium will be excreted, bicarbonate will be reabsorbed inside. So this is a typical channel. So what happens gradually, the patients will also get hyponatremia. Slowly that sodium will be replaced by hypokalemia, and slowly that potassium will be replaced by hypocalcemia. So all these metabolic disturbance can happen. Hyponatremic, hypokalemic, hypocalcemic, hypochloremic metabolic alkalosis. As days goes on, if you're not going to properly treat at one stage, the acid itself will be excreted as a positive ion. So that is known as paradoxical renal aciduria. That is known as paradoxical renal aciduria. So this is a classical finding of any GOO case. Yes, plain chest is detected with the bruising. But when you see a huge bruising, we can have either flail chest or we can have either flail chest or we can have even a pneumothorax. Both are possible. That is meaning the question is incomplete. I want some other clue from the question. I should need some clue like paradoxical respiration is seen. I will go for flail chest. I should say that is a deviation of trachea to go for pneumothorax. Nothing is given in the question. So I therefore went for a flail chest. Because of the huge amount of bruising, I feel that is a multiple rib is fractured. Okay. So this is a classical question: hyponatremic, hypochloremic, hypocalcemic, hypochloremic, metabolic alkalosis. Okay. The answer choice here is A. So hypokalemic, hypochloremic, metabolic alkalosis with hyponatremia. This is a classical question. There is no hypernatremia, there is no hypercalcemia, there is no magnesium will not be seen. So this is the correct answer here. Okay. So 5-year-old boy presented with multiple episodes of hematemesis. See, very small boy having multiple episodes of hematemesis. On admission, he is having a splenomegaly is noted. Mother tells that at birth the boy had developed the jaundice and exchange transfusion procedure has been performed in the same hospital. So probably he had a neonatal jaundice for some cause. What is your diagnosis? Can you come to a diagnosis from this picture? Patient is having portal hypertension. From this scenario given here, patient is having a portal hypertension. So portal hypertension in this age of 5 years is usually due to portal vein thrombosis. This is a pediatric question. Actually, this is not a surgery question. This is a pediatric question. Let me explain you what is actually happening here. This is right side portal vein. This is left side portal vein. This is superior mesenteric vein joining with the splenic vein. This is splenic vein. This is forming the portal vein here. And this is a spleen. So what happens in this boy? This is a young boy. He had probably developed some thrombosis of the portal vein due to neonatal sepsis. The boy probably had a neonatal sepsis. That is why they are giving history of jaundice and other blood transfusion, etc. in the newborn period. So he developed a thrombus of the portal vein, and as gradually this thrombus has completely occluded the portal vein, and that resulted in portal hypertension, that resulted in splenomegaly, and enlargement of the varices. Probably the patient is having varices, because of the varices only he is having hematemesis. So the probable diagnosis therefore in this boy is extrahepatic portal vein obstruction. This is the most common cause of portal hypertension in children. Extrahepatic portal vein obstruction. Extrahepatic portal vein obstruction is the probable cause of this issue. So please remember the patient had a thrombus because of extrahepatic portal vein obstruction. So that is the best answer for this 20th question. So 21st question is a classical urology question. 10 years old boy with a history of recurrent urinary tract infection. The IVP image is shown here. Where will the ureter will go and insert? So they are asking, you can see this picture. This is a normal ureter, and this ureter coming up from upper porno, that is known as ectopic ureter. The question is asking, simple question, the question is asking about the Wiegert-Meyer rule. This is a rule for these cases. Wiegert-Meyer rule. This is actually a little too much question for FMGE exams, but no other way. So this Wiegert-Meyer rule says the ectopic ureter will go distally and drain in the prostatic urethra. It is a direct line from Bailey and Lau. So according to Bailey and Lau, in boys, the ectopic ureter will have obey the Wiegert-Meyer rule. The ectopic ureter from the upper pole will go down and open into the prostatic urethra, and therefore they will have recurrent urinary tract infection, recurrent UTI. They will have therefore recurrent UTI. Okay, not A. Answer is not A. That is not medial, below and medial to trigon of bladder. That is not the correct answer. The most common site of ectopic ureter opening. Ectopic ureter opening in boys is prostatic urethra. In girls is distal to external urethral sphincter. Therefore, girls will have paradoxical urinary incontinence. Paradoxical urinary incontinence is seen in girls. This is there directly from Bailey and Lau. You may not have any confusion at all. This is a picture of ectopic ureter. They are following Wiegert-Meyer rule. Following the Wiegert-Meyer rule. Okay. So identify the pathology shown. This is 100 times asked MCQ. You will never have a doubt in this. What is this sign known as? This is a sign of Barium enema showing you claw or pincer sign. So claw or pincer sign typically seen in intersusception. It is seen in intersusception. It is seen in intersusception. Okay. So please remember this again. A simple. All these image based questions are actually one liner only. All the other images are just one liners. We want you to remember all the one liners. So this is a claw sign or pincer sign showing you the classical finding of intersusception. The most common type of intersusception is ileocholic intersusception. So I am not able to discuss each one in depth, but because for the time constraint for 1 hour discussion, this is only possible. I will do discussion in future in Arise Academy. In your regular classes, I will do all the questions in depth. So don't worry. So this is an ileocholic intersusception, and intersusception is 100 times asked MCQ for you. And you all know very well, FMGE very basic topic is intersusception. Okay. So here, very interesting and this is actually a really ideal question for final MBBS students and for FMG students. So this 45 years old female came for post-surgery follow-up. A chest X-ray was done. So some surgery has been done for this lady and she has come for follow-up. In this picture, what is the finding you are seeing? Classically, you can see this is a picture showing you this. Can you see the outline? This is a picture of soft tissue shadow of right side breast. You can see the right side breast, soft tissue shadow. In the left side, that shadow is missing. So this is a case of left side mastectomy. Very good, Sasi Murugan, very good. It is a left side mastectomy. Excellent. This is a classical case of left side mastectomy. So you can see from the Excel, this is a basic question. These are all questions, you should not make mistake. When you just, without any mind confusion or disturbance, if you observe this very closely, you can see the right side breast shadow, left side breast shadow is absent. So this is a case of left side mastectomy. Left side mastectomy. New question. This question has not come in the exam so far. Definitely this is a new question for your FMG exams. A female patient with a dysphagia. This question has been asked 100 times. Let me tell you, this question has been 100 times asked question. So female patient with dysphagia, barium swallow image is shown. What is the likely diagnosis? You can see the classical bird's beak appearance. This is a bird which is hanging down from upside down. This is a bird's beak appearance. Bird's beak appearance, all of you know the answer. It is Achalasia cardia. So other names are bird's beak, pencil tip deformity, and there is one more phenomenon known as Hurst phenomenon. Some contrast will flow like this. That phenomenon is known as Hurst phenomenon or abrupt cutoff, also known as abrupt cutoff. So all these are various points I want you to remember. Hurst phenomenon, abrupt cutoff, pencil tip. Very good. All of you have answered it correctly. It is not rat tail. That is what I want to tell you. Sasi Murugan, rat tail is not this. So in Achalasia, you will not get rat tail. I will draw what is rat tail now. So please remember, this is a rat. This is a rat. This is a rat. I hope you have seen the rat. The rats will have tail like this. This is irregular narrowing or irregular tapering is known as rat tail. Is irregular narrowing or tapering. Where will you get this rat tail? Rat tail is typically seen in cancer esophagus. Bird's beak is nothing but abrupt cutoff. That is an abrupt cutoff. After that, no contrast is flowing. It is known as abrupt cutoff. Abrupt cutoff, we call it as bird's beak. It is seen in Achalasia. No confusion in this. So the radiologist may tell different answer, but this is a perfect answer. So rat tail is seen in cancer, bird beak is seen in Achalasia. No confusion at all. I want you to be thorough with this. Okay. So the 25th question, classical MCQ again from urology. Urology images will be asked as an MCQ for you. You must remember all the urology images. So this is a picture showing you IVP, showing you the two appearance here. What is the name of this appearance? The ureter is ending like a head like this. What is this? This is known as cobra head appearance. This appearance is known as cobra head appearance. Yes, in esophageal cancer you get rat tail. In Achalasia you get bird's beak. This is cobra head appearance seen in bilateral ureterocele. Classical image, 100 times asked image. This is also a repeat image for you. So please don't forget, all the images in urology may be asked for your exam. So all the images in urology may be asked for your exam. This is bilateral ureterocele. Classical question again. Patient with right hypochondrial pain, water lily sign is seen on ultrasound. What is the diagnosis? What is the diagnosis on a water lily sign? You can see the ultrasound showing you water lily sign. Actually, this question is not asked as an image-based question. It is only a theory question. Water lily sign is seen on dash. So water lily sign is a classical feature of hydatid cyst. Yes, Shweta, we can call it as adder head or cobra head. The both are correct. So this is a classical picture of adder head this is a picture of hydatid cyst. Typically, hydatid cyst seen here with the water lily appearance. There is a classification for hydatid cyst known as WHO classification, in which CE1, CE2, CE3, CE4, CE5 are the types. CE2 is honeycomb appearance like this. There will be multiple honeycomb is known as CE2. CE3 is nothing but this water lily appearance. It is a floating membrane known as water lily appearance. CE1 is a clear cyst. It's a clear cyst. So CE1 clear cyst, CE2 honeycomb, CE3 water lily, CE4 and 5 are calcifications seen. They are nothing but calcifications. Don't worry about 4 and 5. They may ask you honeycomb CE2, water lily CE3 may be asked in the exams for your exam. So please remember these two. Okay. The last question. A 2-year-old child with sudden onset of breathlessness. See, sudden onset of breathlessness, wheezing and decreased breath sounds in the right lung. Chest radiograph shows a diffuse opacity in the right hemithorax. There is a diffuse opacity. What is a probable diagnosis? So please remember, this is a very common scenario. When a baby goes to swallow some foreign body baby is going to swallow. It is usually going to go most commonly into the right side base. The most common site of foreign body in the thorax is going to be on the right lower bronchus. That is most dependent bronchus. So if the baby is going to swallow a coin, that will directly go and occlude this right lower bronchus, or right middle bronchus will be occluded. Therefore, right middle lobe and right lower lobe may be collapsed. The finding will be collapse of these lungs. They will go for collapse, and this is a case of foreign body aspiration. They will go for collapse, and this is a case of foreign body aspiration case, classical MCQ, foreign body aspiration. So that's a fast review of all the 27 questions of surgery. I don't know whether I have missed some questions, because these are the questions I collected from Arise Academy. I thank Arise Academy, Dr. Khalil sir, and other people and the Arise Academy students for giving me the opportunity to discuss these questions, because for getting FMG questions it will be always difficult for me, because I don't have classes for FMG students regularly. So when they get these questions I got from Arise Academy, and I could make these discussions. We'll come up with more discussion on these topics soon. This is just an outline, because this is already late. If you have any doubt, you tell me, or else we will finish the session. We'll meet you on another session soon. Any doubt you have, please tell me. Thank you, surgeon with patient. Thank you. Please just share this video, a fast video of 27 questions in surgery with your friends. So if we take more time also, they will not see the video. That is why I wanted to restrict it at 1 hour exactly. Sai Taruni, thank you, Pa. Thank you so much. So keep preparing, guys. So I'm going to take gastro and urology for you. They have given me some sessions for Arise Academy. It's actually boring, but if it is a live class now, I will definitely come to Hyderabad. Taking an online, no, it is really boring. That is why I'm not interested in taking these online classes. If it is going to be a live class, I will be definitely interested to come and take as much as possible, because I will be seeing you, I will be interacting with you. But taking in this online, no, sitting in front of the laptop and taking it is really boring. Definitely once this lockdown are all over, I will be coming for classes, no doubt. I will take definitely surgical gastro and nephro. Actually, we don't call it as nephro, we call it as urology. We call it as urology in Arise. I will try to take as much as possible, side. The problem is more and more of online classes is boring. Actually, to be frank, the faculties, we are getting bored to take these online classes. We want to have live classes only. Soon we will come for live classes. I will try to take as much as classes possible. Thank you, Sai. Thank you. Thank you, guys. Thank you all. So, all the best for your preparation. Keep preparing. Thank you, Dr. Paul. Thank you so much.